In this session on the reproductive system, we're going to focus on hypertension in pregnancy. Now, hypertension is the most common medical complication of pregnancy. It happens in around about 15 to 20% of all pregnancies. And it's where the maternal diastolic blood pressure greater than 110, this is associated with an increased risk of placental abruption and therefore fetal growth restriction. And if you're looking at these two images, you can see on the left-hand side where you've got this placental abruption. So in other words, the placenta has detached or come away from the walls of the uterus, either partially or totally. And you can see when this occurs, it's quite likely that this can cause bleeding to the mother. And you can see this with the visible bleeding in the image on the left, or concealed bleeding on the image on the right. And of course, it may also interfere with the unborn baby supply of oxygen and nutrients, which of course the placenta provides from the mother's bloodstream through the lining of the uterus. And if they do detach, well, doctors can't reattach them again. So without prompt medical treatment, a severe case of placental abruption can have dire consequences for the mother and her unborn child, and that includes death. So if we're looking at those different types of hypertension in pregnancy, we have chronic hypertension. So that is really just hypertension greater than 140/90, so systolic, diastolic, or both, observed before 20 weeks. You may have pregnancy-induced hypertension. This is hypertension detected mid-pregnancy without proteinuria that returns to normal. There may be pre-eclampsia, eclampsia. This is where you've got that elevated blood pressure greater than 140/90 plus proteinuria after week 20. And of course, eclampsia is about fits, so tonic-clonic seizures. And then you have pre-eclampsia superimposed on chronic hypertension. Just means that there's chronic hypertension before week 20 with superimposed proteinuria, and that may be with or without the symptoms of pre-eclampsia syndrome. And of course, hypertension in pregnancy may cause an increase in maternal and fetal morbidity, and it remains a leading source of maternal mortality. So we're going to just go through each of these in turn, and we'll start with chronic hypertension. And in this case, chronic hypertension, it's considered unrelated to pregnancy, and it's where there's a history of blood pressure greater than 140/90 before pregnancy. Remember, that can be systolic, diastolic, or both. So it can be systolic hypertension or diastolic hypertension. It's therefore unrelated to the pregnancy, but it may be first detected before 20 weeks of pregnancy and then persist after the pregnancy. It's also defined as hypertension detected before 20 weeks of pregnancy where the hypertension does not resolve following birth, hence that second sentence that we just talked about. Remembering, of course, that there are multiple factors that can lead to essential chronic hypertension, but they all revolve around increased vasoconstriction and or elevated cardiac output, and they include things like your race, genetics, blood volume, vitamin D levels, obesity, smoking, salt sensitivity. They're all manner of different factors that affect chronic hypertension. And of course, blood pressure drops slightly in the early stages of pregnancy in women with chronic hypertension. So if you remember from an earlier session, cardiac output goes up during pregnancy, total peripheral resistance goes down during pregnancy, and blood pressure therefore remains about the same. But in those individuals, those women with chronic hypertension, your blood pressure often drops in those early stages of pregnancy. But women with undiagnosed chronic hypertension who don't present for medical care until the latter months of pregnancy may, of course, be incorrectly diagnosed with pre-eclampsia because they're not known hypertensives in the first case. So in pregnancy-induced hypertension, there's a rise in blood pressure in a previously normotensive woman, and it's usually seen in the second half of pregnancy. It includes women with pre-eclampsia who don't yet have proteinuria, which is one of the characteristics of pre-eclampsia. And if pre-eclampsia doesn't develop and blood pressure returns to normal by 12 weeks postpartum, that is when the diagnosis can be made. If the blood pressure is elevated for 12 weeks after birth, then of course the diagnosis becomes chronic hypertension because it is still there a long time after birth. And this affects about 10% of normal pregnancies and is usually benign. And it tends to result from modest perturbations or changes or defects in blood pressure control due to the hormonal changes that are observed in pregnancy. And we've talked about what some of those changes actually are. There's the increase in blood volume via the renin-angiotensin-aldosterone system. There's the reduction in total peripheral resistance, all being mediated, for example, by progesterone and by estrogen, etc. Now we move on to pre-eclampsia. So this is where you may get the presence of hypertension of at least 140/90 after 20 weeks of gestation in a previously normotensive woman. Again, the hypertension can be systolic, diastolic, or both. And at the same time, you need that hypertension in the presence of at least 300 milligrams of protein in a 24-hour urine collection. Edema used to be included in the criteria, but this has been removed. It tends to resolve by about the 6th postpartum week. And like I said, edema is a frequent finding, and it used to be in there, but actually because it doesn't happen in all individuals with proteinuria and with hypertension, it's being taken out. But it is a common finding. And of course, in late pregnancy, pre-eclampsia can progress to eclampsia, and this is when you get tonic-clonic seizures, which are a type of generalized seizure, that affect the entire brain, possibly leading to coma, unconsciousness, and coma. So pre-eclampsia, it occurs in about 5 to 10% of pregnancies, and there are lots of risk factors. For example, a first pregnancy or a prior history of pre-eclampsia, a younger age, less than 18, or an older age, greater than 35, and those who already have chronic hypertension, those who have renal disease or diabetes mellitus, because of renal disease and diabetes mellitus are independent risk factors for hypertension, and therefore, by their very nature, increase the risk of hypertension during pregnancy. And chronic hypertension is more common after pre-eclampsia, affecting 15% of individuals who've had pre-eclampsia at 2 years. And after severe pre-eclampsia, the recurrence rate is about 20 to 25% in subsequent pregnancies. And after eclampsia, which is, remember, is those tonic-clonic seizures, it's about 25 to 30% of subsequent pregnancies will be complicated by pre-eclampsia, but only 2 of those will be with eclampsia again. So just have a little look at this image showing how pre-eclampsia begins to develop. So you can start to see that it starts to develop in the first trimester, and this is where you may start to look at pre-eclampsia screening, so looking for hypertension, for example. And if you're high risk, you may start treatment and closer monitoring, or low risk, normal prenatal care. In the second trimester, you start to see the symptoms of pre-eclampsia, and then the third trimester, of course, you may need early delivery due to severe pre-eclampsia. So what are some of the symptoms? Well, the symptoms appearance are variable, but the higher the blood pressure, the more likely the symptoms. And so, therefore, your complications are more likely to appear at those higher pressures, such as your visual disturbances and your headaches and your epigastric pain and your rapid weight gain through sodium and water retention. And of course, we'll talk about it later, but the sodium and water retention occurs due to the reduced oncotic pressure and associated activation of the renin-angiotensin-aldosterone system. Some of the complications of preeclampsia include eclampsia and associated fetal distress. They can lead to stroke because hypertension is a major risk factor for both hemorrhagic and ischemic stroke. And it may lead to the HELP syndrome, which we'll talk about a little bit later. Remember, eclampsia occurs in about 1% of preeclampsia cases, and the ultimate treatment for preeclampsia is delivery, which is fine if the gestation age is, say, 38 weeks, but not so good if it's at 30 weeks, for example. If it's later on, labour may be induced. If it's earlier, a C-section is usually performed. So, some review questions for you at this stage. Which of the following regarding hypertension in pregnancy are correct? Press pause, have a good read, a good think, and then we'll go through it. Okay, number 1. Placental abruption may occur, disrupting the supply of nutrients to the fetus, potentially leading to fetal death. That is correct. Number 2. Pregnancy-induced hypertension usually develops in the second half of pregnancy with associated proteinuria. That is incorrect. You don't get associated proteinuria in regular pregnancy-induced hypertension. Number 3, pre-eclampsia is diagnosed with a blood pressure less than 140/90, but with 3 grams of proteinuria in a 24-hour urine correction. That's incorrect. Obviously, it's greater than 300 milligrams. It's greater than 300 milligrams of protein in a 24-hour urine collection. And obviously, you need to have a blood pressure greater than 140/90, not less than. Number 4, pre-eclampsia symptoms and complications include visual disturbances, headaches, stroke, and eclampsia. That is correct.